Hi, I'm Dr. Silva, and today I'm going to talk about lithium. Lithium, the original mood stabilizer. Of course, lithium is the third element in the periodic table, atomic number 3. It has 3 electrons, 3 protons, and 4 neutrons, and it is an alkali metal. It is the least dense of all of the metals, and it's found in trace amounts in our bodies, bone and blood and other tissues, with an average concentration of 24 parts per billion. It has the distinction of being one of the least abundant elements in the universe, despite its low atomic number, which is the opposite of what's usually true. Usually, the higher the atomic number of an element, the more scarce it is. So gold is more scarce than hydrogen. But lithium, number 3, is unstable and highly reactive, much like the syndrome that it treats. Although John Cade is credited with reintroducing lithium to psychiatry for the treatment of mania in 1949, the use of lithium in psychiatry actually dates back to the mid-19th century. It was noted that when experimental animals, guinea pigs and such, were injected with lithium solutions, they calmed. And as early as 1870, a Philadelphia neurologist recommended lithium bromide as an anticonvulsant and hypnotic. A year later, William Hammond, professor of diseases of the mind and nervous system at the Bellevue Hospital Medical College in New York, became the first physician to prescribe lithium for mania specifically and, quote, to calm any nervous excitement that may be present. He was one of the first to document that lithium was better than anything else he had tried to calm manic agitation. It was, however, Denmark in the 1890s that became the flagship country using lithium, but not for the treatment of mania. They used it for the treatment and prophylaxis of depression, which is actually what lithium was first studied for, and it's still widely prescribed for today, although it's not approved by the FDA. Then in the early 20th century, not much happened, but by the 1930s, a number of lithium-containing products were on the market. However, not in the United States, and mostly for the treatment of kidney stones, which is ironic because lithium can actually damage the kidneys. It wasn't until 1970 that the United States became the 50th country to admit lithium to the marketplace. So what is it and how does it work? Well, lithium is an element. It's the third element, but it is taken as a salt, lithium carbonate, and there are other preparations. And it's a mood stabilizer. Its mechanism of action is really unknown and probably quite complex. There's no lithium receptor, and it's known to affect the transport of sodium across cell membranes, neuronal and also muscle. But it's really thought to work via a very esoteric intracellular mechanism involving the second messenger system. It's very esoteric. I only have a rudimentary understanding. There are lots of chemicals involved. It's a cascade and G-linked proteins and inositol phosphate. I mean, I learned some of it in medical school. It's ongoing what we learn about these second messengers. They're chemicals that interact with other chemicals that interact with other chemicals. It's a cascade that ultimately goes from the cell membrane down
into the cytoplasm.
And so we don't know how it works. But what's interesting is that if you give lithium to a person that is not affected by a major mood disturbance, someone who doesn't have bipolar disorder, who's not experiencing mania, they have no psychotropic effect, unlike other psychotropic agents.
If you give a benzodiazepine
to someone who's not anxious, they're going to calm, and if you give them enough, they'll get sleepy, and they'll have those psychotropic effects where they might have cognitive dulling and amnesia. They will be affected by the medication. Similarly, if you give someone who doesn't have ADHD Adderall, they're going to be more alert, more attentive, their concentration will improve, their cognitive acumen will improve, they're going to procrastinate less, they're going to have more initiative, they're going to be affected, they're going to have psychotropic effects, not just all the physical effects of taking these medications. But if you give somebody lithium, all you're going to get is side effects. They're going to maybe get the side effects that patients get, but they're not going to get any psychotropic effects. So that's what's interesting about and what's different about lithium as a psychotropic agent. It's a psychotropic agent if you give it to somebody that's having symptoms, and specifically bipolar patients and probably patients with major depression as well. I'll talk about that in a minute. But it's not really a psychotropic agent if you give it to somebody who doesn't have psychiatric symptoms. It's best at treating euphoric mania. It may be a little less effective for mixed states, which is manic states that are dysphoric, that have a lot of anxiety or irritability or just general negativity, and or actual depression. A person can experience depressive symptoms at the same time that they're experiencing manic agitation. That's dysphoric mania. And lithium may be less effective at treating those patients. They typically need other medications, antidepressants, or the third generation, the modern generation of mood stabilizers that have more significant and proven antidepressant actions. Lithium is in general better at treating mania than it is at treating depression. However, as an augmentation strategy, it can be very effective. And in fact, that's another major indication for lithium besides mania and besides bipolar depression. Again, the FDA hasn't approved it for bipolar depression, but as an augmentation strategy, to add on to a regimen where you either have a partial response or you have no response. And it's one of the oldest augmentation strategies that we have because lithium's been around so long. Adding to a person who's depressed who's not responding to their medication. And it can actually convert a non-responder to a responder. And so it's used quite a bit. It may not be used as much as it was once used because there are better medications. So the third generation antipsychotic agents like Abilify and Vraylar are probably more effective. Lithium also dramatically reduces suicidal ideations in patients with endogenous illness. So patients with major depression or patients with bipolar disorder, or especially patients with schizophrenia who are experiencing paroxysmal suicidal ideations, paroxysmal ego-dystonic ideations, that is, ideations that come on very suddenly and very intensely. And they're not necessarily passive ideations. A lot of times when people will have these intrusive, morbid, ego-dystonic suicidal ideations, they're passive, they have no intention. Ego-dystonic, by the way, means that it's troubling to the ego. A person has these suicidal ideations and it doesn't sound good to them. It's not like they're wanting to die. They're having them and they're disconcerted by them because they seem to be coming from nowhere and they're intrusive. But in patients with schizophrenia who are having paroxysmal suicidality, they have these suicidal ideations. They're ego-dystonic. They recognize them as symptoms and they're disconcerted by them, but they actually have the impulse to act. Often there's a specific plan in mind and the patient actually feels like committing suicide suddenly. It's not just that they're having these strange suicidal ideations that seem to be coming from nowhere. No, they're suddenly suicidal. And so it's very dangerous. But lithium has been proven, lithium and clozaril have been proven to dramatically reduce those specific suicidal ideations, the ones that really come on very suddenly. And I actually had one patient that I can tell you had that. He had a diagnosis of schizophrenia or a schizophreniform illness. I believe actually that his diagnosis was schizoaffective disorder, depressed type. And so he would have hallucinations and delusions. He would have episodes, major mood episodes on top of his baseline symptoms. And I inherited him as a patient, and he described these paroxysms of suicidality to me. And then he was hospitalized shortly thereafter. He actually called 911 himself because he was feeling suicidal, and he got himself admitted to the hospital. And while there, he relayed this, and he was started on lithium. And overnight, his suicidality stopped. And he was able to report an overnight convalescence because he was having these suicidal impulses on a daily basis, and he was having them throughout the day. And so this was a symptom that was happening very intensely and paroxysmally, and they stopped. They started lithium, and he told me it was the next day. He himself described how overnight his symptoms abated. That particular symptom abated, and he met discharge criteria a couple of days after that, and I saw him again in my office. But lithium fixed that symptom. And so it's definitely a medication that we think about, and it's easier to use than Clozaril. So it definitely, psychiatrists keep that in mind, but it's a very specific type of suicidality. Side effects. The big three are probably tremor, diarrhea, and weight gain. Weight gain, you definitely see with lithium. You definitely have to monitor that, weigh a patient at baseline, and weigh them periodically thereafter. They definitely would be at risk of metabolic syndrome if you left that unchecked. Diarrhea, because lithium irritates the GI tract, it actually irritates the lining of the GI tract, and diarrhea can certainly be an issue. Tremor is dose dependent, so the more you give, the more you're going to see, and it can actually be an indication of toxicity. It is a side effect, so just because a person has tremor, taking lithium doesn't mean that they are becoming toxic on it, but one of the first signs of lithium toxicity is tremor. And lithium has a narrow therapeutic index. I'll talk about that in a second. But it doesn't take much to go from being tremulous because you're having the side effect to being tremulous because you're on the verge of toxicity. Other side effects are fairly general: sedation, nausea. Those aren't special to lithium. Metallic taste in the mouth is particular to lithium and some other substances, and that makes sense, right? Lithium is a metal after all. It can also cause and or exacerbate acne, and polydipsia and polyuria can be seen. Polydipsia means you're drinking a lot of water, thirsty, and polyuria means you're clearing a lot of water. And that can happen even if the kidneys aren't damaged. However, kidney damage is another potential. It is not common, but you can certainly develop interstitial nephritis, which is an inflammatory condition, and that can occur with or without nephrogenic diabetes insipidus. Now, diabetes insipidus is the other diabetes. It has nothing to do with blood sugar. You have diabetes mellitus, which is the sweet urine, sugar in the urine. This is diabetes insipidus. It is insipid urine. It's not concentrated. There's too much water. And that's occurring because the kidneys aren't concentrating urine. It's because there's kidney damage, nephrogenic, meaning that it starts in the kidneys. This is to contrast it with central diabetes insipidus, which is due to the pituitary gland not releasing antidiuretic hormone, which is what concentrates the urine. So if you don't have enough of that hormone because of the hypothalamic pituitary axis is malfunctioning, then you're going to get diabetes insipidus that is not nephrogenic. But this is the kind that starts in the kidneys because there's a problem with the kidneys. And because you have insipid urine, because you have a very dilute urine, then you also get polydipsia as a consequence. So you're drinking a lot because you're dehydrated a lot of the time. Lithium can also damage the thyroid gland. You can have a goiter, which is enlargement of the thyroid gland, because the thyroid is malfunctioning, hypothyroid goiter, but you can also have a euthyroid goiter, which is enlargement of the thyroid gland, even though it's producing enough thyroid hormone and you're not having any problems with T4 and T3, which are the two circulating forms of thyroid hormone in the body. Now, that's again not common, but it's certainly, you need to monitor the kidneys and you need to monitor the thyroid while you're giving lithium. In patients over age 50, you're also going to want to do a baseline EKG because you can see arrhythmias. Ordinarily, you're not going to see that unless you have an overdose situation. But in therapeutic doses in the elderly, not that 50 or 51 is elderly, but that's the cutoff age for the recommendation. And in an elderly person, you would certainly want to be very careful about using lithium. You might not want to use lithium. And certainly anyone with pre-existing electrocardiographic anomalies. Speaking of anomalies, lithium is also teratogenic. Epstein's anomaly is a cardiac malformation. It's a problem with the valves, and it occurs during the first trimester when the organs are forming. The organs are fully formed by age 9 to 10 weeks. And so this is only a consideration during the first trimester of pregnancy. However, it's a little controversial what the incidence is. It occurs spontaneously, and the incidence is only somewhat higher when you take lithium, when lithium is given, but there's controversy over this, and different research studies have given different statistics as to the incidence, and overall it's thought to be probably an overblown concern. It's a risk-benefit analysis, but I think in a patient who's fairly stable, you don't want to destabilize them by taking them off lithium. I personally would avoid lithium for the first 10 weeks of pregnancy, and if you had to have a mood stabilizer, there are other mood stabilizers that you could use before reintroducing lithium. If a woman is taking lithium during the third trimester, then we do hold it 24 to 48 hours before delivery. For example, for C-sections, if you know the exact date, we do hold the medication so that it's out of the system for approximately a day or two to avoid hypotonia in the newborn, floppy baby syndrome, which you can see. But all you have to do is hold lithium for a couple of days. Lithium has a very narrow therapeutic index. A therapeutic index is a measure of the relative safety of the medication. It is the ratio of the lethal dose to the effective dose. And it's actually the median lethal dose to the median effective dose. Median, not mean. It's not the average.
The therapeutic index is the ratio of the dose that is lethal or toxic in 50% of the population to the dose that is effective in 50% of the population.
And so, obviously, the higher that number, the higher the dose has to be in order to harm you. The lower that ratio, that means that the safety window of that medication is very low, that it doesn't take very much to harm you. And that's the case with lithium. Lithium has a very narrow therapeutic index. The dose that it takes to kill you is not that much higher, relatively speaking, than the dosage that it takes to actually help. And we have a further problem with lithium in that you could be taking the same dosage day after day, but if you become dehydrated, that's going to increase the serum concentration of lithium, which is the important thing, even though you haven't upped your dosage. And so a person can become toxic if they become suddenly dehydrated. The level of lithium is definitely going to go up, and you're definitely going to have maybe some symptoms like increased tremor or nausea or vomiting, but it can progress to seizures, coma, and death. The package insert states that the optimum therapeutic range for lithium is between 0.8 and 1.2 milliequivalents per liter. And so that's what we aim for, and research has actually shown that less than that, and you don't get a therapeutic effect. Greater than that, and you're bound to get toxicity. And so you try to keep it at that range for acute episodes. For maintenance, you probably do okay with a lithium level between 0.8 and 1 milliequivalents per liter. But you don't really want to go lower than 0.8 because at that point you start to lose efficacy. What are the signs of lithium toxicity? Well, it is potentially fatal in overdose. It starts with tremors, and you could certainly have GI distress, nausea and vomiting, ataxia, which is an unsteady gait. You're not steady on your feet, and that can progress to fatal arrhythmias, seizures, coma. So you could die in any number of ways, from a fatal heart rhythm to status epilepticus to falling and hurting yourself. So staying hydrated is very important, and that is lithium in a nutshell. It sounds like a high maintenance medication. You certainly have to monitor it. You do have to watch the kidneys and watch the thyroid and take lithium levels to establish where you are, and it usually has to be dosed more than once a day. There is an escalate controlled release that can be dosed once a day. Actually, the current thinking is that it's just as effective or even better to take it just once a day in the evenings. And so that's typically what we do. We use a long-acting preparation, give it in the evenings with food to help protect the lining of the GI tract. And we get pretty good results with it, pretty rapid results. Again, for the treatment of acute mania, for the prophylaxis of manic episodes. We also use it to augment depression when we already have other antidepressants on board, to convert partial responders or non-responders to full responders. And we use it to decrease suicidality, in particular paroxysmal suicidality in patients with endogenous illness. And it is inexpensive, and if you have a patient who can be responsible about taking their medication and who can guard against becoming dehydrated, it's very effective, and it was the original. It's still in use today.